Hello, sir.
Hello, good evening, madam.
Good evening, sir.
Uh, shall we start, madam?
Yes,
I
sir.
think yesterday, up to I think malaria we have covered. I think.
Yes, sir. From malaria, I'll
So,
start today.
yeah. Please proceed.
Yes, sir. Okay, sir. So, hello, everyone. Welcome to Tawhid Foundation at Allied Healthcare Sciences, Bangalore. So, today's class is about parasitology. So, in last class, we studied about introduction to parasitology, importance of parasitology, types of host. There are four types of host: definitive, intermediate, reservoir, parentenic, and last is vector. Parasitic life cycle, that is direct and indirect. Host parasitic interaction, that is of four types: symbiosis, commensalism, parasitism, and last is mutualism.
No.
Classification of parasites, diagnosis, and one by one all parasites, Entamoeba histolytica. Next is Balantidium coli, then Trichomonas vaginalis, Giardia, Leishmania, and now we'll start with malaria. So, malaria is an infectious disease that is caused by any one of five species of protozoa, that is Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malaria, Plasmodium knowlesi. So, out of these five species, any species can cause malaria. Plasmodium is an unicellular obligate parasite that infects the red blood cells, liver, and brain. So, among 150 species of Plasmodium, only 5 can affect human, and they are these 5 species. So, among these species of this parasite, Plasmodium falciparum is the deadliest species which dominates the African continent, where Plasmodium vivax is the most prevalent in other tropical and subtropical countries and is the main cause of relapse of malaria. So, overall, the other three species are less prevalent. Worldwide, the dominantly widespread effect of this parasite is due to its transmission through the vector mosquito. Transmission of malaria. So, malaria does not directly transmit from an infected person to a healthy person, but there are various indirect routes that can help spread the diseases. These are like vector. The malarial parasite mostly transmit through a mosquito vector, specifically the infected female Anopheles mosquito. Thus, malaria is classified as a vector-borne disease. Infected female Anopheles mosquito transmit the infective stage parasites to a healthy person during blood feeding, where the exchange of mosquito saliva occurs before blood can be sucked. So, second is blood transfusion. Sometimes malaria also get transmitted when the blood of infected individuals comes in contact with the blood or bloodstream of healthy individuals. This usually happens during blood transfusion or during the sharing of needles. Nowadays, blood transfusion is usually preceded by numerous blood screening tests which greatly eliminate the risk of such transmissions. However, the spread of parasites from individuals who shares or reuse the contaminated needles, especially drug users, are still relevant. Mother to fetus, a pregnant woman who has malaria is capable of transmitting the parasite to her fetus through the placental route. However, in such cases, the infection of the placenta itself is much more probable than the fetus getting infected. An infected placenta will prevent oxygen and nutrients from being passed to the baby, leading to severe outcomes such as miscarriage. Life cycle of Plasmodium. Life cycle of Plasmodium is that of a cyclic nature that alternates between the female Anopheles mosquitoes and humans. So life cycle, there are two types of life cycle. First is human, that is gametocyte and merozoid life cycle. Second is mosquito phase. So in human, the parasite initially proliferates in the liver cells and then the red blood cells of humans. Within the red blood cell, Plasmodium develops into schizons, which ruptures red blood cells to invade other neighboring RBCs. The schizons then develop into merozoites. This stage of the Plasmodium life cycle is responsible for causing symptoms of malaria. Some parasites differentiate to form sexual erythrocyte, which are known as gametocyte. Eventually, the gametocyte forms of the parasite are ingested by the female Anopheles mosquito during blood meals, which signal the start of the second life cycle. Like second mosquito sporozoid life cycle, the gametocyte mate in the gut of the mosquito and beginning a new cycle of proliferation. So after about 2 weeks, a form of the parasite known as sporozoites travel to the salivary glands of the mosquito. When the female mosquito begins a blood meal on a healthy human, a certain amount of mosquito saliva is transferred into the blood to act as an anticoagulant. This causes the transfer of the Plasmodium sporozoid into the human bloodstream. The sporozoid then migrates to the liver through the bloodstream, beginning a new human life cycle. So, when female Anopheles mosquito bite human, they seek for proteins present in the blood which are needed for the development of their eggs. Thus, only female mosquitoes are responsible for mosquito bites and thus play a role in the transmission of malaria. This is the life cycle. These two terms are very important, sporozoite and mesozoite. In this diagram, you can go through clinical features. The incubation period in human after getting bitten by an infected mosquito is usually around 10 to 18 days long, within 2 weeks on average. Symptoms of malaria are the primary symptoms include high fever and sweating, fatigue, chills, unconsciousness, anemia, jaundice, cerebral malaria, convulsions and muscle spasm, breathing complications, dark or bloody urine, jaundice usually characterized by yellowing eyes or skin, abdominal bleeding. In some cases, malarial symptoms may be mild for people, especially those who have already been infected by the parasite before. Complications and diagnosis. Complications for some specific population groups, the onset of malaria can be specially fatal. These include infants, children under 5 years of age, pregnant women, travelers, and HIV and AIDS patients. When left undiagnosed, these cases can quickly turn fatal. Diagnosis. Malaria is one of the deadliest disease and requires a thorough and immediate response. Usually, diagnostic methods involve identification of the parasite itself or the products produced. Although it seems simple, the efficiency of diagnosis depends and can be influenced by various factors such as 5 different species, drug resistance, stages of life cycle, all this. Clinical diagnosis. Okay, so it is the least expensive and widely practiced method where malaria is endemic. It is based on examining the sign and symptom of the patient. Sometimes there may be non-specific signal that lead to overtreatment of malaria or not treating malaria at all. This method include thick and thin blood smear, RDT, and molecular PCR. Treatment and prevention. So, laboratory diagnosis, treatment and prevention. Treatment include artemisinin-based therapy for Plasmodium falciparum, chloroquine for Plasmodium vivax, primecune for Plasmodium vivax, or ovule relapse prevention. Prevention, you can take mosquito control, chemoprophylaxis, vaccines, RTS, AS1, R21, matrixim. Next is spore. So cryptosporidium. Microsporidium, cyclosporidium. So these are spore-forming intestinal protozoan parasite. It is mainly infect the digestive tract, causing diarrheal illness. It will affect both immunocompetent as well as immunocompromised individuals with more severe diseases in patients having AIDS and HIV, as well as malnourished patients. Transmission is through contaminated food, water, or person to person spread. It is resistant to standard chlorination and can persist in the environment. So the spore forming intestinal protozoa, that is Cryptosporidium, Isospora and Cyclospora, all these are important intestinal pathogens in both underlying health issue patients. Cryptosporidium, Isospora and Cyclospora are coccidian parasites that predominantly infect the epithelial cell lining the digestive tract. Microsporidia were formerly considered spore-forming protozoa and have recently been reclassified as fungi. Microsporidia are ubiquitous, obligate intracellular parasites that infect many other organ systems in addition to the gastrointestinal tract and cause a broader spectrum of diseases. So we'll start with Cryptosporidium. It is recognized as a leading protozoal cause of diarrhea in children worldwide and is a common cause of outbreaks in childcare centers. It is also a significant pathogen in immunocompromised patients. Its etiology: Cryptosporidium hominis and Cryptosporidium parvum cause most cases of cryptosporidiosis in humans. Disease is initiated by ingestion of infectious oocytes that release four sporozoites that invade enterocytes primarily in the small intestine. The infection progresses through two stages. First is the asexual stage, which allow auto-infection at the luminal surface of the epithelium, and the next one is sexual stage, which result in production of oocytes that are shed in stools. The cysts are immediately infectious to other hosts or can reinfect the same host as well. So its epidemiology is associated with diarrheal illness worldwide and is more prevalent in developing countries and among children under 2 years of age. It has been implicated as an etiologic agent of persistent diarrhea in the developing world as a cause of significant morbidity and mortality from malnutrition, including permanent effects on growth. Transmission Transmission is to humans can occur by close association with infected animals via person to person transmission or from environmentally contaminated water. Although it is zoonotic transmission, especially from cows, occurs in person in close association with animals, hospitals and childcare centers. Reaccommodations to prevent outbreaks in children care centers include strict hand washing, use of protective clothes or diapers capable of retaining liquid diarrhea, and separation. Clinical features: the incubation period is around 2 to 14 days. Infection with Cryptosporidium is associated with profuse watery non-bloody diarrhea that can be accompanied by diffuse crampy abdominal pain, nausea, vomiting, watery diarrhea, anorexia, fatigue. Although less common in adults, vomiting occurs in less than 80% of children with cryptosporidiosis. Non-specific symptoms such as megalgia, weakness, and headache also may occur. Fever occurs in 30 to 50% of cases. Malabsorption, lactose intolerance, dehydration, weight loss, and malnutrition often occur in severe cases. Recently, the clinical spectrum and disease severity has been linked with both the infecting species and host. In immunocompetent patients, the disease is usually self-limiting, although diarrhea may persist for several weeks and oocyte shedding may persist many weeks after symptom resolves. So chronic diarrhea is common in individuals with immunodeficiency such as congenital or HIV infection. Symptoms and oocyte shedding can continue indefinitely and may lead to severe malnutrition, wasting, anorexia, and even than death. So, cryptosporidiasis in immunocompromised host is often associated with biliary tract disease characterized by fever, right upper quadrant pain, nausea, vomiting, as well as diarrhea. Diagnosis: infection can be diagnosed by microscopy using modified acid fast stain or PCR polymerase chain reaction, but enzyme linked immunosorbent assay are the diagnostic method of choice. In stool, oocyte appears as small spherical bodies and stain red with modified acid fast staining because cryptosporidium does not invade below the epithelial layer of the mucosa. Fecal leukocytes are not found in stool specimen. Oocyte shedding in feces can be intermittent and several fecal specimens should be collected for microscopic examination. Serologic diagnosis is not helpful in acute cryptosporidiasis. In tissue sections, cryptosporidium organism can be found along with microvillus region of epithelia that line the GIT. Treatment: often the diarrheal illness due to cryptosporidiasis is self-limited in immunocompetent patients and requires no specific antimicrobial therapy. Treatment should focus on supportive care including rehydration orally or if fluid losses are severe intravenously. So nitazoxanide uh, for children around 1 to 3 years of age will be given. Treatment of diarrhea caused by cryptosporidium. Clinical studies have not been demonstrated that nitazoxanide is superior to in trials. So HIV patients will be given combination therapy and as well as supportive therapy, that is oral rehydration and nutritional support. Next is Isospora belli, that is which will cause isosporiasis. Like cryptosporidium, Isospora belli has been implicated as a cause of diarrhea in institutional outbreaks and in travelers and has also been linked with contaminated water and food. Isospora appears to be more common in tropical and subtropical climates and in developing areas including South America, Africa, and Southeast Asia. Isospora has not been associated with animal contact. It is also an infrequent cause of diarrhea in patients with AIDS, but may infect up to 15% of AIDS patients. The life cycle and pathogenesis of infection with Isospora species are similar to those of Cryptosporidium organisms, except that oocytes excreted in the stool are not immediately infections but must undergo maturation below 37 degrees Celsius. So histologic appearance of GIT epithelium reveals atrophy, acute and chronic inflammation. Clinical features: the clinical manifestations are indistinguishable for those of cryptosporidiosis, although fever may be a more common finding. Eosinophila may be present, contrasting with other enteric protozoan infection. The diagnosis is established by detecting the oval around 22 to 33 μm long oocytes by using modified acid-fast staining of the stool. Each oocyte contains two sporocysts with four sporozoids in each. So diarrhea, it is watery and non-bloody. Fever, abdominal cramp, anoxia. Eosinophila may occur, which will differentiate in feature and more severe cases in AIDS patients. Diagnosis and treatment: again acid fast stain, it will show oocytes of this size. Treatment: oral treatment for allergy. Cipro drug of choice will be given. For AIDS patient, maintenance therapy is must required. Next is Cyclospora. Cyclospora cayatinensis is a coccidian parasite similar to but larger than Cryptosporidium. The organism infects both immunocompromised and immunocompetent individual and is more common in children less than 18 months of age. The pathogenesis and pathologic findings of cyclosporiasis are similar to those of isosporiasis. Asymptomatic carriage of the organism has been found, but travelers who harbor the organism almost have diarrhea. Outbreaks of cyclosporiasis have been linked with contaminated food and water. Implicated foods include raspberries, lettuce, basil, snow peas, and other fresh food items. So, after fecal excretion, the oocyte must sporulate to become infectious. These findings explain the lack of person to person transmission. Clinical features: incubation is around 7 days. Symptoms will include watery diarrhea, abdominal bloating, cramps, fatigue, headache, low grade fever, and duration it will last around 10 to 25 days, and it will take long period of time in immunocompromised individuals. Diagnosis and treatment: acid fast stain and auramine phenol staining under autoinflorescence UV. Treatment: drug of choice will be given. Alternative is ciprofloxacin or nitazoxanide. Next is microsporidia. Microsporidia are ubiquitous and infect most animal groups, including humans. At least 14 species of the phylum Microsporidia have been linked with human disease in both immunocompetent and immunocompromised hosts. The species most commonly associated with GIT, gastrointestinal disease, are Enterocytozoon and Encephalizoon intestinalis. These two, although still not definitive, the source of human infection is likely zoonotic, like Cryptosporidium. There is concern for waterborne transmission through occupational and recreational contact with contaminated water sources. There is also the potential for foodborne outbreaks. The organisms have been identified on vegetable as a consequence of contaminated irrigation water. Vector-borne transmission is because one species typically infect mosquitoes. Finally, transplacental transmission has been reported in animals but not in humans. Diagnosis and treatment. So, diagnosis: modified trichome stain, molecular method PCR, and electron microscopy will be done. Treatment include drug of choice, supportive care, again rehydration, and antiretroviral therapies in HIV patients. Prevention and control: strict hand hygiene and sanitization to avoid and will hand sanitization. Second is avoid untreated water, boil or filter water before consumption, wash fruits as well as vegetables thoroughly, protective gloves for food handlers, control outbreaks in childcare centers and healthcare facilities. Okay, so in today's class, we studied about uh, these spores, cryptosporidium, which will lead to cause watery diarrhea in children, which and it is resistant to chlorine. Isospora, larger oocytes, which will respond to TMP and SMX. Cyclospora, it is caused by foodborne outbreaks. Autofluorescent oocyte. Microsporidia, it is an opportunistic infection. It requires special stainings. Summary: comprehensive overview of parasitology, definition of parasites, their structure, physiology, and interactions with hosts, types of host, four types of host: definitive, intermediate, reservoir, and paratenic, vectors, direct and indirect, complex life cycles of parasites, major groups covered in today's class. Protozoa is done. We'll continue with now helminthes and arthropods, which focus on laboratory diagnosis using morphological, cultural, immunological, and molecular techniques such as DNA probes as well as PCR. So Entamoeba histolytica, it causes amoebiasis and is spread via contaminated food or water and show variable pathology from asymptomatic to severe dysentery and liver abscesses. Balantidium coli, it is a ciliate protozoan found in the large intestine, mostly asymptomatic but causes dysentery in vulnerable hosts. Next is Trichomonas vaginalis, a flagellated protozoan transmitted sexually, mainly causing vaginitis and urethritis. Giardia duodenalis it causes giardiasis, which is a food and waterborne infection leading to diarrhea and malabsorption. It is prevalent in children and is resistant to chlorine treatment. Leishmania donovani, it is an intracellular parasite causing kala azar, that is called as black fever or visceral leishmaniasis via standfly transmission with complex host or vector life cycle and severe clinical features. Plasmodium species, it causes malaria with transmission via Anopheles mosquito. Only female mosquito will transmit infection. Clinical features and treatment are outlined alongside prevention strategies. Coccidian protozoan is Cryptosporidium, Isospora, and Cyclospora. Cyclospora associated with enteric disease, mainly in immunocompromised or children. It is transmitted via water or foodborne with clinical and diagnostic features. Detailed microsporidia, it is ubiquitous in nature, it infects many organ systems as well. It mainly causes chronic diarrhea in immunocompromised hosts detected by microscopy and PCR. Question part for 3 marks. So there are 10 questions. Define a parasite and differentiate it from host. Second is name the type of host involved in a parasite's life cycle with one example each. Third is what is a definitive host? Give an example related to Plasmodium species. Fourth is list three major laboratory diagnostic methods for parasitic diseases. Fifth is name two medically important protozoan parasites that infect the human intestine. Sixth, what is the infective stage of Entamoeba histolytica? Seventh, mention two morphological features of Balantidium coli trophozoite. Eighth, how is Trichomonas vaginalis mainly transmitted? Ninth, what is the primary reservoir host for Leishmania donovani? Last is state two control measures for preventing foodborne giardiasis. For 5 mark questions, first describe the life cycle of Entamoeba histolytica and its clinical manifestation. Second, explain the different type of host, definitive, intermediate, reservoir, and paratenic with example of each from medical parasitology. Third, discuss the laboratory diagnostic techniques for detecting parasitic infections, including morphological and molecular method. Fourth, summarize the transmission, pathogenesis, and symptoms of Balantidium coli infection. Fifth, explain the morphology, life cycle, and laboratory diagnosis of Trichomonas vaginalis. Sixth, write about the epidemiology, clinical features, and prevention of giardiasis. Seventh, outline the morphology, life cycle, and diagnosis of Leishmania donovani as the causative agent of Kala-Azar. 8. Discuss the transmission cycle, laboratory diagnosis, and treatment strategies for malaria. 9. Compare the clinical manifestation and diagnosis of cryptosporidiosis and cyclosporiasis. Last is describe the significance of microsporidia in human disease and outline the laboratory diagnosis and treatment. So, can we continue with Helminthis? Hello.
Hello, madam.
Yes, sir. Can we continue
Uh,
with Helminthis part?
yeah. Acha, today itself, huh?
No, yes, sir. Today itself. I'll
Okay,
continue.
madam.
Time is there,
Yeah,
no?
yeah. Yeah, yeah.
Oh,
Please
okay,
continue.
sir. Okay. So, so now next part is Helminthis. So Helminths. Medical helminthology is concerned with the study of helminths or parasitic worms. Helminths are trophoblastic metazoa multicellular organisms. Helminths are among the common parasite causes of human sufferings. They are the cause of high morbidity and mortality of people worldwide. They cause different diseases in humans, but few helminthic infections cause life-threatening diseases. They cause anemia, malnutrition. In children, they cause a reduction in academic performance. Helminths also cause economic loss as a result of infections of domestic animals. There is age-dependent distribution of infection from geohelminthes and schistosomes as a result of predisposing behavioral and immunological status. So children disproportionately carry the burden of schistosomes and geohelminthes. The sources of the parasites are different. Exposure of humans to the parasites may occur in one of the following ways. First is contaminated soil, which is caused by geohelminthes, water, flukes, and food, that is tinea, in raw meat. Second is blood sucking insects or arthropod, as in filarial worms. Third is domestic or wild animals harboring the parasite, as in echinococcus in dogs. Fourth is person to person, as in Anterobius vermicularis, Hymenolophis nana. Next is on self, the autoinfection, as in Enterobius vermicularis. And last is entry through mouth, skin, and respiratory tract. They enter the body through different routes, including this mouth, skin, and the respiratory tract by means of inhalation of airborne eggs. The helminthes are classified into three types, three major groups. These are trematode, that is flukes or flatworms. Second is nematode, that is roundworms, and last is cystodes, that is tapeworms and flatworms. This is the structure of flukes. A, that is hermaphrodite fluke, and this one is bisexual fluke. So trematodes belong to the phylum Platyhelminthes. They are found in a wide range of habitats. The great majority inhabited the alimentary canal, liver, bile duct, ureter, and bladder of vertebrate animals. Adult flukes are leaf-shaped, as you can see in this picture. Leaf-shaped flatworms, prominent oral and ventral suckers help maintain position in situ. Flukes are hermaphrodite except for blood flukes, which are bisexual. The life cycle includes a snail intermediate host. According to the sites they inhabit, there are four groups of flukes. These are blood flukes, intestinal flukes, liver flukes, and lung flukes. So we'll start with blood flukes. These are flukes that reside mainly in the blood vessels of various organisms. The schistosomes are the prototype and the commonest flukes in our country. Schistomiasis, it is estimated that about 600 million people in 79 countries suffers from schistomiasis. These schistosomes cause intestinal, hepatosplenic, pulmonary, urogenital, cerebral, and other forms of schistosomiasis. This schistosome is the only fluke with separate sexes. The female worm lies in the gynecophorial canal of the male. This condition is important for transportation. So there are five medically important species. First is Schistosomasa mansoni. Next is Schistosoma hematobium. It causes visceral urinary schistosomiasis. Next is Japanicum. Next is Intercalatum. And last is Mekongii. Japanicum, it causes intestinal schistosomiasis. Intercalum, it causes again intestinal, last as well intestinal schistosomiasis. This seem to cause a milder disease in men. It causes disease in another vertebrate host. So the first two schistosomes, Mansoni and Hematobium, are prevalent. Its habitat, this species live in the veins of the intestine. This Mansoni lives in the veins of the intestine. It is found in Africa, South America, Middle East, and some Arab countries. Streams and lake-based transmission is common. The snail is the host that harbor Cystosoma mansoni. Genera is Bioflaria and Probicorsis. These have oval shells Its morphology: male ranges in size around 1 to 1.4 centimeter in length, and the body is covered by coarse tubercles. It has 6 to 9 testes. Female is around 1.5 to 2 centimeter in length. The ovary is present in the interior third, and vitelline glands occupy the posterior two-third. It lays about 100 to 300 eggs daily. In this Mansoni species, the uterus is short, containing few ova. Next is schistosoma hematobium, that is urinary schistosomasis. It's habitat: the worm lives in the veins of the bladder of humans. The peak prevalence is the 10 or 14 year of age group. The snail host that harbors are the genera. So male ranges in size around 1 to 1.5 centimeter in length, while female ranges around 2 to 2.5 centimeter in length. Its distribution: it is found generally in Kenya. This species is prevalent in South and Western Kenya. Next is Japonicum. The female adult worm lays about 500 to 3,500 eggs daily. The eggs are ovoid, bearing only a minute lateral spine or small knob posterior lateri. It is found in Japan, the species, China, and Philippines. Intercalatum: this is the rarest and least pathogenic schistosome that matures in men. It is found in Western and Central Africa. The daily egg output is about 300. The eggs have a terminal spine. Last is Mekongii. It is related to Japonicum, distributed along Mekong River and its certain distributaries in lower Cambodia. Its transmission is through skin penetration by cerci. Clinical features is dysentery, hepatosplenomegaly, bladder carcinoma. All this comes under clinical features. Diagnosis: stool or urine exam for eggs, lateral or terminal spine. Treatment: choice of drug, praziquantel will be given. So, life cycle of schistosomes. Adult worms reside in pairs. The female lying in the gynecophoral canal of the male. After fertilization, eggs are passed into the venules. A larval form, the merachidium, develops within the egg. Its lytic enzyme and the contraction of the venule rupture the wall of the venule, liberating the egg into the perivascular tissues of the intestine or urinary bladder. So the egg pass into the lumens and other organs and are evacuated in the feces or the urine. One contact with fresh water from the egg and swim about until they find appropriate snail which they penetrate. After two generations of sporozoite development and multiplication within the snail, the fork-tailed cerci emerge. Infection to man take place during bathing or swimming. The cerci penetrate the skin, are carried into the systemic circulation and pass through the portal vessels. So within the anteraheptic portion of the portal system, the worms feed and grow to maturity. Mainly infection is caused when person is swimming or in water. Next is fasciola, that is liver fluke. So its species is Fasciola hepatica and Fasciola gigantea. So here Fasciola hepatica, ship liver fluke, it is common parasite, cosmopolitan in distribution. It is large, around 3 centimeter in length. Adult worms reside in the large biliary passage and gallbladder. Fasciola gigantica, it is lives in the liver of cattle. Human infections are very rare in these cases. So fasciolate Liasis is caused by Fasciola hepatica and less often by Fasciola gigantica, which are flat worms classified as liver flukes, that is trematodes. Some human cases have been caused by hybrid species. Additional Fasciola species have been found in animals. Snails' intermediate host is the genus Limnia. So, its life cycle: Fascicular parasites develop into adult flukes in the bile ducts of infected mammals which pass immature fascicular eggs in their feces. So transmission is through ingestion of metacercari on aquatic plants. Clinically, it is biliary colic. It causes jaundice, hepatomegaly, as well as liver damage. Diagnosis is through eggs in stool or bile. Treatment drug of choice triclabendazole or bithionol will be given to patients. Next is nematodes. Nematode is nothing but roundworms. So in nematodes, two species is included, Ascaris lumbricoides, and next is Anclytoma and nectar. So we'll start with Ascaris. Its transmission is through fecal oral route. All the important human parasite of the phylums Helminthis belong to the class Nematoda. Its general characteristics, they are unsegmented, elongated and cylindrical. They have separate sexes with separate appearances and find each other via pheromones. So they have a tough protective covering or cuticle. They have a complete digestive tract with both oral and anal openings. The nematodes are free living majority of parasites in humans, plants or animals. So the parasitic nematodes are generally light cream white colored. The life cycle includes egg larva and adult. The parasitic nematodes are divided into intestinal nematodes with tissue stage and intestinal nematodes with blood dwelling. So its clinical features include abdominal pain, growth retardation, Lofer syndrome. Diagnosis is again through stool microscopy. Eggs will be visible. Treatment, drug of choice is albendazole and mebendazole will be given. This is the diagram which will show the life cycle of Ascaris. So, intestinal nematodes with tissue stage roundworms include Ascaris lumbricoides. Next is hookworms, that is nectar and cyclotroma, larval migrants, and third is threadworms, that is Trongiodites stercolis. So its morphology, male adult worm measures around 15 to 20 centimeter in length. The posterior end is curved ventrally. The female worm measures around 20 to 40 centimeter in length. Its posterior end is straight. Infective stage and mode of infection. The egg containing larva when ingested with contaminated raw vegetable causes ascariasis. So roundworms infect human via the fecal oral route. Eggs released by the adult female are shed in feces. The eggs are ingested via food. Ingested eggs hatch in the duodenum into the larva. The larva then penetrate the intestinal wall and circulate in the blood to the lungs before entering the throat. The person may either swallow or cough out the larva. If swallowed, the larva move into the intestine via the trachea, descending to the esophagus and finally reach the small intestine to become adult. It will become adult ascariasis. The female pass immature eggs which pass to the soil and mature in 2 weeks. Pathogenicity and clinical features. This is the egg of Ascaris lumbricoides. Its pathogenesis and clinical features. Ascariasis may not cause symptoms at first. However, as the infestation inside the small intestine grows, a person notices symptoms such as abdominal pain, loss of appetite, worms visible in stool, vomiting, impaired growth in children, weight loss, nausea, diarrhea, and irregular bowel movements. So, in advanced infection, the worms travel to the lungs and may present symptoms such as fever, discomfort in the chest, gagging cough, bloody mucus, shortness of breath, and wheezing. In rare cases, the patient may experience a complication known as aspiration pneumonia, that is Lofer's syndrome. This is Lofer's syndrome. So, diagnosis, examination of stool for eggs by direct saline smear method. Second is demonstration of adult worms via imaging techniques such as
Hello.
endoscopy. Hello, yes, sir.
Madam, did you share this one slide, sir?
It is not visible, sir.
No, actually, here 3 marks questions it's showing.
Oh, I I think I don't know. So from that time I was explaining it is
Yeah,
nothing
yeah,
but
because that's what I'm thinking. Whether
it now it is visible, sir.
just a moment. Now it's visible, madam.
Oh, I didn't know, sir. Okay, I'll give in short. So this
Yeah.
introduction, helminthes, it is a multicellular parasite worms. It causes morbidity, anemia, malnutrition, reduced academic performances, and it is age-dependent infection distribution. But children is affected the most. Economic losses due to the infection in domestic animals. Sources is through contaminated soil or water or food. There are two types of helminthes, geohelminthes, and tinea. Blood-sucking insects, it will cause failure worms. Domestic and wild animals, example is Echinococcus in dogs. Person to person is Enterobius vermicularis. Next is autoinfection. It is causes Enterobius hymenophyes nana. Entry is through mouth, skin, and respiratory tract. Classification, there are three types of helminthes: trematodes, which include flukes or flatworms; nematodes, it includes roundworms; cystodes, it include tapeworms, that is flatworms. Trematodes, so there are four types of trematodes: uh, uh, blood trematodes, liver trematodes, lung trematodes. So we'll go one by one. Schistosoma, that is blood fluke. There are five most common species: Schistosoma mansoni, Schistosoma hematobium, Schistosoma japonicum, Schistosoma intercalatum, Schistosoma meconigi. Transmission is through skin penetration by cerci. Clinical features include dysentery, hematuria, hepatosplenomegaly, bladder carcinoma. Diagnosis is through stool or urine examination. X is seen. Treatment is drug of choice praziquantel. Structure of fluke. This is the diagram of hermaphroditic fluke, and that this is bisexual fluke. Life cycle of schistosomes. Next is fasciola, that is liver fluke. It is caused by fasciola hepatica and fasciola gigantea. Transmission is through ingestion of metacercariae on aquatic plants. Clinical feature causes jaundice, hepatomegaly, biliary colic, as well as liver damage. Diagnosis is through presence of eggs in stool or bile samples. Treatment, drug of choice, traclea, bendazole, or bithionol will be given. Next is nematodes, that is nothing but roundworms. It is divided into two: ascaris, lumbicoids, that is roundworms, and tapeworms. So transmission is through fecal, oral contaminated food or water. Life cycle, it will occur in intestine and then pass through lungs, swallowed in intestine. Clinical features is abdominal pain, growth retardation, and Loeffler syndrome. Diagnosis is stool microscopy. X is visible. Treatment is albendazole and mebendazole. Life cycle of Ascaris. Eggs of Ascaris, lumbricoids. So now we'll start with hookworms, that is Ancylostoma and Necator. Hookworm is an intestinal parasite of humans. The larva and the adults live in the small intestine of the host, causing intestinal diseases. There are two species of hookworms. First is Ancylostoma duodenal. Next is Necator americanus. So the adults are found in the small intestine of men. It is a common mixed infection. The eggs are passed in feces of an infected person. The eggs hatch into larvae which can penetrate the skin of human. Hookworms infections are transmitted primarily by walking barefoot on contaminated soil. Ingestion of the larva can also cause infection. It's a life cycle of hookworm. So In ankylostoma, grayish white in color, the body is slightly ventrically curved. The anterior end follows the body curvature. The buccal cavity is provided ventrically with pairs of teeth and dorsally with a notched dental plate. Distribution of this ankylostoma is found in the northern part of the world, including China, Japan, Europe, North Africa, and Ethiopia. Its morphology: male measures around 10 centimeter in length. The posterior end is broadened into membranous copulary bursa that is provided with two long spicules. Female measures around 12 centimeter in length. In ankylostoma, the posterior end is straight. In Necator, this species, so-called American hookworm, is found in predominantly the tropics. The anterior end is hooked against the body curvature. The mouth is provided ventrically and dorsally with cutting plate. Its morphology: male measures in 8 centimeter in length. The posterior end is broadened into a membranous copulatory bursa which is provided with two long spicules fused distally. Female measures around 10 centimeter in length. The posterior end is straight. Infective stages: the filiform larva infects through skin penetration by barefoot walking. Clinical features include anemia, malnutrition, dermatitis, and cough. Diagnosis is through stool samples, which will show the presence of eggs. Treatment include albendazole drug, mebendazole plus iron supplements. Life cycle of hookworm. Adult male and female worms live in the small intestine. The female lay eggs which contain immature embryo in the 4-cell stage. When the egg pass in the stool to the soil and under favorable condition of temperature, moisture and oxygen, they hatch into larvae. They release the larvae which grow in the feces or soil, and after 5 to 10 days they become filariform that are infective. When the filariform larvae penetrate the skin, they circulate in the blood to the heart. It reaches the lung, ascend to the trachea and descend to the esophagus to reach the small intestine, and where they reside and become adults. So some species of duodenal larvae, following penetration of the skin, can become dormant in the intestine and muscles. Pathogenicity: it will cause skin rash on area that is typically red and itchy, weight loss, loss of appetite, breathing complications such as wheezing and a cough, fever, stomach pain, diarrhea, extreme tiredness and weakness, iron deficiency, anemia, as well as malnutrition. So the larva cause inflammation of the lungs. Treatment and diagnosis: examination of stool and drug of choice, as I mentioned earlier. Prevention: avoid walking barefoot in areas where hookworms are common. Use barriers to prevent the skin from touching the soil when sitting on the ground. Avoid consuming soil or unwashed food that may be contaminated by hookworm. Avoid defecating outdoors. Avoid the use of human feces as fertilizers. Effective sewage disposal systems. Next is Enterobicus vermicularis, that is pinworm. So Anterobius vermicularis is a small white worm with thread-like appearance. The worm causes enterobiasis. Infection is common in children. Morphology: the male measures around 2 to 5 mm in length. The posterior end is curved and carries a single copulatory spicule. Female measures around 8 to 13 mm in length. The posterior end is straight. Infective stage: infection is by ingestion of eggs containing larvae with contaminated raw vegetables. So mode of infection: by direct infection from a patient through fecal route. Auto-infection: the eggs are infective as soon as they are passed by the female worm. If the hand patient get contaminated with these eggs, he or she will infect again and again in auto-infection. Contaminated clothes, bed linens, etc., is the transmission of this pinworm. Clinical features include nocturnal anal itching, appendicitis, it is very rare, Diagnosis includes sellotape swab, that is perianal eggs. Treatment include albendazole and mebendazole drugs. Next is strongyloids stercococcus, that is threadworm. Transmission is through skin penetration or autoinfection is possible in this case. Clinical features include diarrhea, pneumonia, disseminated infections, and underlying health issue patients. Diagnosis larva, presence of larva in stool samples. Treatment is given thiabendazole. This is the life cycle of strongyloids stercoralis in the body of host and external environment. You can refer this image for the life cycle. It is the larva of stercoralis. Next is trichuria, that is whipworm. Its transmission is through the ingestion of embryonated eggs, which is contaminated in food or soil. Clinical features include bloody diarrhea, rectal prolapse, anemia in children. Diagnosis is stool examination. In diagnosis, barrel-shaped eggs will be visible under microscope with plugs. Treatment include albendazole and mebendazole. This is the life cycle of trichuria. Next is Trichinella spirosis, which will causes trichinosis. Transmission is through undercooked pork meat, especially. Clinically, intestinal phase, it will occur inside intestinal phase, which will cause diarrhea, muscle spasm, myalgia, periorbital edema, and myocarditis. Diagnosis is through muscle biopsy. It will given for biopsy examination. Serological tests include. Treatment is given albendazole and thiabendazole. Next is Dracunculus medinensis, which is caused through Guinea worms. Transmission is through contaminated water with copepods. Clinical features include blisters on legs, that is red in color, small patches. Worm emerges, systemic allergic reaction. You'll get small boils on throughout the body. Diagnosis, clinical observation, blisters or worm. Treatment in given mechanical removal stick method or wound care. Ointment, topical solutions will be given. Prevention is nothing but filtration of water before drinking. Next is Wucheria bancrofti, which is caused by filarial worm. Vector, it is caused through mosquito bite. Clinical features include lymphatic filariasis. It also includes elephantiasis, hydrocele, lymphangitis. Diagnosis is microphilia in blood. Night sample should be given for diagnosis and serological test. Treatment include diethyl carbamazine, that is DEC, prevention, mosquito control, and bed nets. This is the life cycle of Muncheria bancrofti. Other inferior worms include Onchocerca volvulus, that is river blindness transmitted by black fly. Loa loa, that is eyeworm transmitted by chrysops fly. Clinical features include skin nodules, dermatitis, corneal opacity, and caliber swellings all over the body. Treatment include ivermectin and DEC, albendazole, and mendazole is the very common drug of choice for this helminthus infection. Next is cystodes, that is tapeworms. Tinea solium, which is caused by pork tapeworm. Transmission is through undercooked pork consumption, which will cause intestinal teniasis. Eggs will be visible, that is cysticercosis. Clinical features include abdominal pain, epilepsy. Diagnosis, stool examination. Eggs will be visible, proglottids, imaging cyst formation will be seen. Treatment, paraziquantel and albendazole will be given to patients. Next is Tinea saginata, which is caused by bear tapeworm. Transmission is through again undercooked beef. Clinical features is intestinal infection, no cysticercosis, will be seen. Diagnosis is through stool microscopy, proglotids, treatment, praziquantel. Next is Echinococcus granulosus, that is hydatid worm. Transmission is through ingestion of eggs from dog feces. Clinical features include hydate cyst in liver, lungs, as well as brain. Diagnosis, imaging, therapy, and serological tests include treatment. Again, albendazole plus surgical removal through pair method will be done. This is the life cycle of Echinococcus granulosus. Next is fish tapeworm, that is Diphyllobothrium latum. Transmission is again through raw or undercooked meat. Freshwater fish. Clinical features is megaloblastic anemia, B12 deficiency, abdominal discomfort. Diagnosis is through stool examination. Eggs will be visible with operculum. Treatment is praziquantel. Next is Hymenolepsis, that is Nana dwarf tapeworm. Transmission is through again ingestion of eggs. Autoinfection is very common. Clinical features include abdominal pain, diarrhea, anorexia, especially in children's infants. This disease will cause. Diagnosis includes stool examination, treatment, niclosamide, and praziquantel. So summary. Today in today's class we learned about nematode, that is schistosoma and fasciola. Nematodes include Ascaris. In Ascaris types and cyclostoma, Anterobius, strongyloids, Trichuris, Trichinella, Dranculus, Wucheria, and other types of nematodes. Cystodes include Taenia species, Echinococcus, Diphyllobothrium, Hymenopsis. Common route is transmission, which is through contaminated food, water, soil, or vectors. Clinical features include anemia, malnutrition, organ damage as well. Prevention, hygiene is the most important. Cooking food, it should be well cooked. Raw meat contain all this helminths vector control. Questions for 3 marks. First, define helminthology and name the three major classes of helminths. Second, list two sources of parasite transmission in humans with example. Third, write two clinical features of schistosoma hematobium infection. Next is state the infective stage and mode of transmission of Ascaris lumbricoides. Fifth is mention two complication caused by hookworm infection. Sixth, what is the diagnostic method for Enterobius vermicularis? Seventh, name two clinical features of trichuria infection. Eighth, give two preventive measures for Dracunculus medinensis. Ninth, what is the causative agent of Hydatid disease and its definitive host? Last is name the parasite associated with vitamin B12 deficiency and its mode of transmission. Five more questions. First, describe the life cycle of Schistosoma mansoni, five type of species which I mentioned earlier. Second is explain the pathogenesis, clinical features, and treatment of Fasciola hepatica. Third, discuss the life cycle and complication of Ascaris lumbricoides. Fourth, explain the transmission, clinical features, and diagnosis of hookworm infection. Fifth, write a short note on strongyloids stercoralis with emphasis on autoinfection. Sixth, describe the clinical features, diagnosis, and prevention of Trichinella spiralis infection. Seven, discuss the morphology, life cycle, and clinical importance of Wucheria bancrofti. Eighth, explain the mode of infection, clinical features, and diagnosis of Tinea solim, which is caused by the consumption of pork tapeworm. Ninth, write a note on Echinococcus granulosus, that is hydatid disease, including diagnosis and treatment. Last, describe the transmission, clinical features, and laboratory diagnosis of Diphyllobothrium latum. So that's all for today's class. One part is pending, that is laboratory diagnosis of pathogenesis, and last is arthropods. So inshallah in next class we'll cover that. So
Thank you, madam. Thank you so much.
thank you, sir.
In between, I think without slide,
Uh, Yeah,
Just
I didn't know. I thought
uh,
it was visible, but I
yeah,
didn't
yeah.
know
Some
that
I think might be.
last PPT is only showing.
Yeah, yeah. No
Oh,
issue. It will happen because
yes.
it's there.
Because I don't know what is visible. For me,
Yeah,
in
yeah.
my screen, it is showing another PPT, but it was not shared properly, I guess.
Message properly. Yes, yes.
Okay, sir. Thank you so
Okay.
much.
Thank you. Thank you. Thank you so
Thank
much.
you, sir.